Helping others is a calling.
For a lot of the community, we are the only hope. We're the light at the end of the tunnel for a lot of them.
We serve the poorest of Rochester. Baden is that beacon of hope.
Baden Street is trusted, and people will come in and ask for help. And I think we have to help no matter what.
Baden believes in the community. I believe in Baden Street as a whole. I was a Baden Street kid. The reason I stay here at Baden Street is because I see the impact of it. We need a little sunshine, a little ray of hope, and Baden Street, it can be that.
My goal is to help the families become self-sufficient, as Baden Street has taught me to become self-sufficient. I love Baden Street. I mean, Baden Street has done more than enough for me, and I just have to give it back.
I came to Baden Street when I think I was 13 or 14. It impacted me because I learned the road I should go on, the right road.
It takes a village to raise a child. That's what Baden Street did for our community. They helped to raise all of us. Just made me proud of myself and of my community where I came from.
Baden Street allowed me to be myself and be creative. I gained my passion of art, and I went to school for art.
I grew up in this neighborhood. I grew up coming to Baden Street as a child, to be able to come now as a senior. And it gives us a sense of we belong, we are a community, we're one big happy family.
To ensure that our students have a place in the world, that they know that they can either stay within the Rochester community or travel globally, that they are citizens of the world.
We offer everything from childcare to preschool to mental health and drug services. We have clothing rooms, food pantries, that they can get help with pretty much anything that they might need assistance with.
I worked for Baden Street for 53 years because of the fact that Baden Street was so instrumental in my growing up that it gave me the opportunity to give back.
Baden has been in the community for 120 years. Baden is deep rooted in people's hearts and soul. I've been working here at Baden for 12 years. I departed briefly to try other ventures, not realizing that this was home. And for me, being able to come back, I feel that here I can make a difference.
Everything that I did in my life led to me being here in this moment, servicing the people who need it most.
I believe people can change. I believe in being a cheerleader for those that accomplish.
Ultimately, if I can make a difference, a positive impact in someone's life, that really is my ultimate goal.
I'm doing something that I'm passionate about. And I think when you lead by your passion, you never work a day in your life.
It just warms my soul. It just makes me super excited, super happy to come into work every day, just because I see the impact that not only I'm making, but the impact that my coworkers are making.
The 30 years that I've been at Baden Street, I can say that the impact that it has had on me and my family, as far as the children that we have experienced, that we have groomed to be the adult educators, to be the adult firefighters in our community. Baden Street has been the soul of the community.
I had an applicant that came in, they were filling out their paperwork. We met in the hallway and it brought tears to my eyes, it brought tears to her eyes because I had not seen her in 10 years. But she was 10 years sober and now she came back to work at Baden Street, to give back to Baden Street because of the things that Baden Street had done for her. I mean, that is what Baden Street really is.
Baden Street is very special, and it always has been, and it always will be.
There will always be problems, but we have to teach people to believe in themselves, and we have to teach people that there are ways out.
To have the people in this community walk into a building that's beautiful, that speaks to them and their needs and their community, that we care, I think that's going to be a significant transformation.
As long as Baden Street grows with the community, it'll be a staple in the community for another 120 years. Baden believes.
Baden believes.
Baden believes.
Baden Street cree. Baden Street believes.
Baden believes.
Hey guys, first thing I want to say is it was a great video. If we can we give another round of applause for the video? Great video. Good evening to everybody. Thank you. My name is Robert Derisaw, and I'm proud to serve as the Director of Metro Council for Teen Potential here at Baden Street Settlement. Thank you guys so much for being here today with us. Tonight isn't just a milestone. It is a moment to focus on the work ahead. We gather at a time where the barriers to health, opportunity, and justice remain painfully real, not just in our own neighborhoods, but across our city, our state, our nation, and the world. At Baden, we face those barriers head on. For 124 years, this organization has stood with people who've been overlooked, underserved, and underestimated. And we have never backed down. Tonight is about recommitting to that work with urgency, with clarity, and with community. We're honored to welcome Dr. David R. Williams, a national and global authority on health equity and systemic injustice. His research has shaped how we understand the impact of racism and structural inequality on human health, and what must be done to change it. Following his keynotes, he'll be joined in conversation by Dr. Lakia Wilson, Vice President of Community Engagement and Social Impact at Rochester Regional Health, who will help guide a powerful discussion on what equity can look like in practice. But before we begin, we open with music, a voice that captures the strength and spirit of this community. Please join me in welcoming the incredibly talented Santrice Green performing Rise Up.
You're broken down and tired of living life on a merry-go-round, and you can't find the fighter, but I see it in you, so we gon' walk it out and move mountains. We gon' walk it out and move mountains. And I'll rise up, I'll rise like the day, I'll rise up, I'll rise unafraid, I'll rise up, and I'll do it 1,000 times again. And I'll rise up, high like the waves, I'll rise up, in spite of the ache, I'll rise up, and I'll do it 1,000 times again. For you, for you, for you, for you. When the silence isn't quiet and it feels like it's getting hard to breathe, and I know you feel like dying, but I promise we'll take the world to its feet and move mountains. Bring the world to its feet and move mountains. And I'll rise up, I'll rise like the day, I'll rise up, I'll rise unafraid, I'll rise up, and I'll do it 1,000 times again. For you, for you, for you, And that's why we have each other. And that's why we have each other. And we will rise, we will rise, we will rise. Oh, we'll rise. And now rise up, rise like the day. I'll rise up in spite of the ache. I will rise 1,000 times again, and we'll rise up high like the waves. We'll rise up in spite of the ache. We'll rise up and we'll do it 1,000 times again for you, for you.
Amazing song. If everybody please can help me welcome the Norman Professor of Public Health at Harvard University, Dr. David R. Williams.
And good evening. It's truly an honor and privilege to be here with you this evening. I have spent an inspiring day touring the Baden House settlement, and just the history and what you're doing. It's just amazing, remarkable, and inspiring. I'm going to jump right into my talk since I have a lot of territory to cover and precious little time. So I want to address the topic of reducing inequities in health, the fierce urgency of now. There are large racial ethnic differences in health in the United States and around the world. One example is infant mortality, the chances of a baby dying before its first birthday. And you could see in the United States, Blacks or African Americans, Native Hawaiians and other Pacific Islanders, American Indians, Alaska Natives, and Latinos all have elevated rates of infant mortality compared to whites. For the Latino population, if we separated the US-born versus the foreign-born, the US-born is true for all immigrant groups. The US-born have higher rates than the immigrant groups. Just to give you one other example from another country, this is from the United Kingdom. Pakistani, Blacks from Africa, Bangladeshi, Blacks from the Caribbean, Indians, all have higher rates of infant mortality than the white British population. But I have examples from multiple countries. It is, in fact, a global phenomenon. Not only do these inequities exist, but they have existed for a long time. So one example of that is looking at life expectancy at birth. How long will the average person live? And you could see in 1950, the average white person lived 8 years longer than the average African American. The good news is every decade, life expectancy has increased for African Americans, it has increased for whites, and the 8-year gap in 1950 was a 4-year gap in 2010. At the same time, these are striking inequities. Look at the life expectancy of whites in 1950, 69.1 years. How long did it take for African Americans to catch up to the health that whites had in 1950? 40 years later, in 1990, African Americans experienced the level of health that whites had in 1950. And then things have gotten worse. So that if we look at 2020, you can see life expectancy decline for whites. It declined for African Americans. The decline for African Americans was greater. So while there was a 4-year gap in life expectancy in 2010, there's a 6-year gap in 2020. What happened? 2 things. One is the COVID-19 pandemic that had a disproportionate negative impact on minority populations. But there is a second factor that has played a role. Since 2019, the all-cause mortality has been rising for the youngest Americans, age 1 to 19, being most pronounced by those in the range of 10 to 19. It's driven by marked increases in suicides among our youth, as well as access to firearms and other factors that are playing a role. But this is a really disturbing trend in the overall patterns. Now, I'm talking about racial inequities in health. Let me break it down. What does it really mean when I say there are racial inequities in health? Well, there's a 2023 paper in the Journal of the American Medical Association that has shown us that because of racial inequities in health, 74,000 Black people die every year who wouldn't die if there were no racial differences in health. On a daily basis, that's 203 Black people dying prematurely every day. Imagine a fully loaded jumbo jet with 200 passengers and crew on board and crashing every day and everybody on board dying. Can you imagine how that would wake up America? Well, we need to wake up because that's exactly what's happening when we say there are racial inequities in health. 200 Black people dying prematurely every single day in the United States. And these racial inequities are costly. They are costly to the U.S. economy. There are so many examples, I'm not going to go through all of them, of the economic impact that these inequities are having. They are also costly in another way. Because of racial differences in health, Blacks have more deaths of friends and relatives in childhood and throughout the life course. One analysis showed, compared to whites, Black children are 3 times as likely to lose a mother by age 10. Black adults are twice as likely to lose a child by age 30 and a spouse by age 60. This loss of social ties is a unique stressor that is a side effect of these inequities in health. Martin Luther King said of all the forms of inequality, injustice in health is the most shocking and the most inhumane because it often results in physical death. So what drives these large racial inequities in health? Why do they exist? I'm trained as a sociologist, and I know that socioeconomic status, whether measured by income, education, occupational status, or wealth, is a central determinant of the distribution of every valuable resource in society, including health. This is not a US phenomenon, this is a global phenomenon. And race ethnicity is strongly related to socioeconomic status, the SES. So here is national data for the United States, median household income by race and ethnicity. I'm presenting the same data in a way you can't miss the point. I'm standardizing on the household income of whites as $1. For every dollar of household income white households receive, Asian households receive $1.23. Couple caveats. Asian households are more likely to be multi-generational than any other racial group, have more persons contributing to household income. A second factor is Asian households is heavily made up of immigrants, more than any other group. Also has a higher level, almost twice the level of college completion as the white population. So those factors need to be kept in mind. Something also to keep in mind throughout my talk today, I'll talk about these broad groups, but recognize there is what scientists call heterogeneity. There's variation within each group. So the Asian household with the highest levels of income, there are 3 subgroups of Asians: the Hmong, the Laotian, the Cambodian, that have lower levels of income than African Americans, for example. So recognize that there's variation within all populations. But let's go back to the data and the disadvantaged groups. For every dollar of household income white households receive in 2018, Latino households receive 73 cents, and Native American and African American households receive 59 cents. Do you know what is stunning for that 59 cents figure for Blacks? That is identical to the Black-white gap in income 40 years ago. In 1978, as a result of the civil rights policies of the 60s and 70s and the war on poverty of the 60s and 70s, the gap was worse than 59 cents. It got to 59 cents. And 40 years later, it is still 59 cents. Has it been stuck at 59 cents all this time? No, it got worse throughout the decade of the 1980s. I'll come back to this. Reaganomics was not good to the Black population. And it was not until 1996, during the Clinton era, that it got back up to 59 cents, and there's a penny up and down since then. The important take-home point is that we have made much less progress than most Americans think. There's a movement in America against DEI because DEI is discrimination against whites, and blacks and other minorities have gone ahead. We have not made that much progress. And the large gaps in income markedly understate the racial gaps in economic status. What do I mean when I say that? Well, income captures the flow of resources into the household. It tells us nothing about the economic reserves that households have to cushion shortfalls of income. We get that from data on wealth that captures your financial assets, your home equity, your other resources. And according to the Federal Reserve Board, for every dollar of wealth white households have, black households have 10 pennies, and Latino households have 12 pennies. And when you are low in income and low in wealth, we could have all been in the same storm of the pandemic, but we were in different boats. Because when you're low in income and low in wealth, you don't have the capacity to weather the storm as well. When my career started, most researchers thought that racial ethnic differences in health were simply a function of racial ethnic differences in income and education, because socioeconomic status is a powerful driver of health. And they assumed that if we looked at blacks and whites at the same level of income and education, race would no longer matter. We now know that life is more complicated than that, and I'm giving you an example from a paper we published years ago using national data for the United States, life expectancy at age 25. And at age 25, the average white person lives 5 years longer than the average black person. So remember, there's a 5-year racial gap. But if we look within whites by education, whites with a college degree or more education live 6.4 years longer than whites who have not finished high school, even bigger than the racial gap. And if we look within African Americans, those with a college degree live 5.3 years longer. Again, 5.3 is bigger than 5, than the racial gap. So if the economic factor is a bigger driver than the racial factor, should we abandon collecting data by race and just report data by income and education? And I would say not so fast. Why? Because race still matters at every level of income and education. So, for example, whites who have dropped out of high school live 3.1 years longer than blacks who have dropped out of high school, and that gap widens as education increases. And this is a stunning statistic I'm showing you, and this is national data for the United States. The best off African Americans, those with a college degree or more education, have lower life expectancy than whites with a college degree, lower life expectancy than whites with some college education, lower life expectancy than whites who've graduated from high school. So what do these data tell us? That there's something about income and education that matters for your health regardless of your race. But they also tell us that there's something else about race that matters even after you've taken income and education into account. And so researchers have been asking the question, what else is it about race that matters and matters so profoundly? And the research is clear that racism is alive and well, pervasive and thriving in America, and has negative consequences for health. What do I mean by racism? I think of racism primarily not as the beliefs and behavior of individuals, but as a societal system. A system that ranks and categorizes populations, differentially allocates opportunities and resources. It's premised on the ideology that some groups are better than others, and it can lead to negative attitudes and beliefs, prejudice, and stereotypes. It can lead to differential treatment, discrimination by both individuals and institutions. But remember, racism is primarily a system. So I want to unpack racism here for you briefly. Structural or institutional racism is one mechanism. This is a paper I wrote back in 2001 about the fundamental driver of residential segregation producing inequity in the United States. John Sell was a historian at Duke University. He wrote a book about the origins of segregation in the US South and South Africa. He showed and argued that residential segregation by race was the single most successful domestic policies of the 20th century in the United States. It's beneath the radar screen. No politicians are talking about it, but it's a driver of inequities in everything in our society. He also showed that the framers of apartheid in South Africa got the idea of apartheid in the late 19th and early 20th century by looking at how well residential segregation was working in the United States, and just decided to tweak it. And somebody says, but what does segregation have to do with anything? Think of segregation as a burglar at midnight. Once it shows up in a community, valuables disappear, like quality schools and safe playgrounds and access to good job opportunities and a healthy environment and safe housing and high quality transportation and high quality medical care. Scientific research shows all of these desirable resources vary by where you live in these United States, varies by your neighborhood, all of these desirable resources. But let's look at evidence. William Julius Wilson and Robert Sampson are two of America's most eminent sociologists. They studied 171 largest cities in America and said there's not even one city where whites live under equal conditions to those of blacks, and that the worst urban context in which whites reside is considerably better than the average context of black communities. And if you look at that, that was a 1995 study. So you say, well, have things gotten better? I want to share with you the work of one of my colleagues, was at Harvard. She's now at Boston University, Dolores Acevedo Garcia. She's created a Neighborhood Opportunity Index. This version of it ranks every census tract and county in America on 29 different indicators of access to opportunity for kids, like the quality of schools and the high school graduation rate and the median household income and access to high quality air and water, exposure to pollution, resources for health. And she studied the 100 largest metropolitan areas in America. And she asked, which children live in very low and low opportunity neighborhoods? 67%, 2 out of 3 black children, 58% of Latino kids, and 53% of Native American kids live in very low and low opportunity neighborhoods, compared to 1 in 5 white and Asian kids. Who lives in high and very high opportunity neighborhoods? Almost 2/3 of white and Asian kids, compared to 1 in 5 black and Latino kids. So place is a driver of access to opportunity in American society. That's a 2020 paper, and things have not changed since then. In fact, research indicates that segregation is the central driver of the racial differences in income and education that we encounter in the first place. Don't take my word for it. This is David Cutler, Dean of the Social Sciences at Harvard University, one of the country's leading economists, using fancy econometric models I cannot even fully describe, but looking at using national data, he shows statistically that if you could eliminate residential segregation in America, you'd completely erase black-white differences in income, in education, and in unemployment, and reduce racial differences in single motherhood by 2/3. All of those striking differences are linked to opportunity at a neighborhood level. One more study, one more Harvard economist, Raj Chetty. He's done an amazing intergenerational analysis. He got access to all census data from 1989 to 2015. And he asked the question, let's look at black and white children who begin life in households with the same parental income. How are the children doing in the next generation, right? Income is the same for the parents, black and white. How are the children doing? And he found that black boys have lower earnings than white boys in 99% of census tracts in America. Why? Because they're lazy? No. Because they're not working hard enough? No. They live in neighborhoods that differ in access to opportunity. Black boys do as well as white boys if they're in neighborhoods with good resources. Very few of them have the opportunity to live in those neighborhoods. What do these data tell us? They tell us that the inequities in socioeconomic status and other resources that matter for life and health do not reflect a broken system. No, they reflect a carefully crafted system, functioning as planned, successfully implementing social policies, many of which are rooted in residential segregation, a mechanism of racism. In other words, the inequities we see are not accidents, they're not random events, they're not acts of God. They reflect the extent to which racism has produced a truly rigged system in these United States. So I've talked about structural racism and upstream mechanism. One mechanism, it's not the only one, but residential segregation. I want to talk about individual discrimination. as an added source of stress. Martin Luther King suggested this. He said discrimination is a hellhound that gnaws at Negroes in every waking moment of their lives, declaring that the lie of their inferiority is accepted as the truth in the society dominating them. I've developed measures to capture the stress of racism. One of them that I have developed is called the Everyday Discrimination Scale. Does not capture all dimensions of racism, but just the little indignities. Today, there are more than 500 published peer-reviewed papers from around the world documenting the negative effects of everyday discrimination. And to illustrate that, I'm showing you the work of Dr. Tenny Lewis, an African-American scholar, was at Yale when she did this, now at Emory University. Each line is a different published paper. Higher levels of everyday discrimination, links to coronary artery calcification, links to inflammation, links to higher blood pressure, links to lower birth weight infants among pregnant women, links to more rapid declines in cognitive function, links to poorer sleep, is an independent predictor of premature death in longitudinal studies. Links to visceral fat, shorter telomere length, just to give you an example of the impact that racism has. Stress is an important pathway, and racism is not the only stress. This is a study we did in Chicago with other colleagues. African Americans and US-born Latinos had high levels of racism, but it also had high levels of major life events like the death of a loved one, financial stress, work stress, relationship stress, neighborhood stress. And we found a dose-response relationship between all those stressors and physical health and mental health. And segregation, research indicates, leads to higher levels of physical and chemical exposure. This is the work of Robert Bullard. He has been a pioneer in this area of looking at the negative impacts of chemical exposures, and he shows in segregated neighborhoods, there's just such a broad range of negative exposures to physical and chemical toxic substances. There are also hidden ways in which stressors linked to racism affect health. I'm going to illustrate it with one study I did with one of my former students, Jacob Bohr. We got a database of every police shooting in the United States. And we linked that to a database from the CDC of the mental health of the population in every state. And we found that every police shooting of an unarmed black person led to worse mental health, not just for the family and friends of that person, but for the entire black population in which that state occurred, and elevated symptoms of mental health were elevated for 3 months. A spillover effect. These things have consequences. And it's an example of ways in which racism also affects. But then, so I've talked about structural institutional racism, individual discrimination. There's also racism embedded into our culture, our beliefs, our stereotypes, and they trigger the way in which we react to others. And one influential study, I served on the committee that produced the Unequal Treatment Report back in 2003, that documented across virtually every therapeutic intervention in America, blacks and other minorities receive poorer quality care and less intensive care than whites. Last year was 20 years after the report had been released, and there was a lot of interest in how have things changed. By the way, that's the Washington Post, that's the national press conference at the time of the release of the report. And basically, all the progress we have made is more evidence documenting the problem, not progress in reducing it. Let me give you one example. National data for the United States, 318,000, all of them with the same insurance, Medicare insurance. They all have the same diagnosis. They have advanced cancer in their last weeks of life. The question is, do they get opioid medication for their pain? They're dying of cancer, right? Blacks and Hispanic patients with advanced cancer are less likely than white patients to get opioid medication for their pain. When they get medication, blacks and Hispanics get a smaller dose, a lower dose than their white counterparts. And black patients were more likely to undergo urine drug testing. They're dying of cancer, right? But they're more likely to undergo urine drug testing to see if they're abusing opioids. And black men experience the greatest inequality in terms of being the least likely to get opioid access and the most likely to go through urine drug testing. And that is a 2023 paper. The problem persists. in these United States. What can we do? This is a paper I wrote with Lisa Cooper from Johns Hopkins, summarizing there's a lot that we can do, and I want to just highlight a few things. We need to ensure access to care for all, improve the quality of care. I'm going to elaborate a little bit on diversify the workforce to meet the needs of all patients, and provide care that addresses the social context. Here is a study, high-quality randomized control study, where they took black men in Northern California and give them a coupon to go to a Saturday clinic. They had options of getting a range of screening for different problems. When they got to the clinic, they were randomized to see a black patient, black provider, or provider of a different race. The black men who saw a black doctor were more likely to talk about other health problems, more likely to do the screening for diabetes, more likely to get the flu vaccine, more likely to do the screening for cholesterol. Greater engagement with the healthcare system when there was racial concordance. A study of US counties published in 2023 found that if there are more primary care African American physicians in the county, the life expectancy of the entire black population is higher in that county. It's the progress that we have made. In the mid-1916, 2.9% of all physicians in the US were black. Today, 5% are black, 6% Latino. We have not made much progress. And someone said, but we've had DEI, we've had affirmative action. Did it work for anybody? Yes, it did. It worked for women. 6.9% of medical school students were female in 1965. By 2010, 48%. And today, it's 51% every year. Most of these women have been white. The biggest beneficiaries of DEI and affirmative action have been white households in the United States. Digest that in this context where DEI is under attack. The biggest beneficiaries have been white households in the United States. And the different diversity success outcomes for women versus minorities highlights that you need to not only open the door of opportunity, but people need to be enabled to walk through the doors. Women were able to walk through the doors. Blacks still face poorer education in the communities in which they live. So what else can we do? Provide care that addresses the social context. The World Health Organization asks, what do we accomplish if all we do is treat illness and send people back to live in the same conditions that made them sick in the first place? Let me give you the example of a randomized controlled trial, the highest quality of scientific evidence, that took 244 low-income patients, 80% of them black, randomized them to 3 conditions. 1, go to your doctor, get your medical care, your hypertensive medication, and go home. The second group, in addition to going to the doctor and getting your medication, you go to a class, a health professional for 12 weeks, teaches you about the importance of blood pressure. And the third group, went to the doctor, got their medication. They took lay people from the community, give them 1 month of training in basic information about blood pressure, but also basic information of all the resources that existed in the community to help people with problems that they face. 7 months later, those who were in the outreach group knew twice as much about blood pressure than people in the other 2 groups. They were also more compliant, taking the blood pressure medication as they were supposed to. And among good compliers, blood pressure medication was twice as successful in controlling blood pressure than in the other 2 groups. What was different about the outreach group? The health problem was understood and addressed within the context of their lives. And folks, this is a randomized control study published in 1978. This is not new information. Why aren't we doing this more in these United States? I want to share with you a couple innovations in healthcare delivery quickly. The Boston Medical Center, the safety net healthcare facility in the United States, has added lawyers to the medical team. So a primary care provider can refer to a number of specialists. And one of the specialists they can refer to is a lawyer. Because if a mother brings a child with asthma, and the asthma is secondary to the housing conditions in which they live, and the mother's complained to the landlord who's done absolutely nothing, all the asthma medication in the world is not going to help that child breathe symptom-free if the child goes back to live in the same conditions. And it makes a difference when a lawyer calls and says, you're violating the housing code of Massachusetts, we'll sue the landlord if you don't fix the problem. It's an example. This medical legal partnership is now in more than 250 hospitals in the United States, following the example of the Boston Medical Center. Another program, Boston Medical Center, is providing, while people are waiting to see their pediatrician, they get screened for financial challenges they face in their lives. And this is the pediatrician who developed this program that they screen for financial problems and then they intervene on them in terms of helping them get resources that exist. This program has provided not only financial training and literacy training, but it's provided help in tax preparation. A lot of Americans who are eligible for earned income tax credit don't file for it. It has helped since 2016 to get 6,000 families to get more than $14 million in tax refunds. And it all begins while you're waiting to see the doctor in the pediatric waiting room. Another example. This is an example from the great state of Kansas. In Wichita, Kansas, Arnitha Martin was a nurse practitioner, African-American, grew up in that community, encountered the lack of access to quality of medical care. And she decided to do something about it. I want to illustrate what one person can do. And she single-handedly raised money from the business community to open a center of 8,000 square feet with 6 exam rooms that sees 15,000 patients a year. And I visited the center, and I was impressed. Every person who enters the center knows that your insurance or your income has nothing to do with the quality of care you received, because you only ask questions about what insurance you have, how you will pay for the care at the end of your visit after you've received all of your care. And you can pay $10 off your bill for every hour volunteered at the center. You can also get $10 off your bill for every hour you spend in a health education or wellness class at the center. It's just innovation of what she's done. And then, one of the things that took me to when I visited the center was a room called the Stork's Nest. It has everything an expectant mother would need for a baby. And if a woman keeps up her prenatal visits as she's supposed to, she gets points. And at the end of her pregnancy, she can cash in those points and get everything she needs for as a baby. Just an example of innovation in medical care. Another example is having nurses make home visits to pregnant women. This has been done, randomized controlled trials of white women in upstate New York, Elmira, in Memphis, Tennessee, African-American women, Denver, Colorado, Latinas. It works everywhere. Having nurses make home visits to pregnant women leads to better birth outcomes and saves society money. Even though it's expensive to send nurses in, there's reduced child abuse and neglect, subsequent pregnancies, and welfare and food stamp use as a result of that intervention. What else? Bringing some experienced mentors to the table. This is Experience Core, where they take retired seniors and they go and volunteer at schools, and what the research has documented, there are benefits for the children and benefits for the seniors as a result of this volunteering. I'm sharing with you innovations that are happening across America today that's making a difference. What else do we need to do? Identify supportive, protective factors and resilience resources. I'll give you one example. Dr. Jean Brody, a study in rural Georgia, assessed discrimination among African-American teens at age 16, 17, and 18, and those who were stably high on discrimination by age 20. I didn't say age 30 or 40, by age 20, they have higher levels of stress hormones, cortisol, epinephrine, norepinephrine, higher levels of blood pressure, higher levels of inflammation, higher levels of BMI at age 20, linked to exposure to discrimination as a teen. However, they reanalyzed their data. And for those kids who experienced high levels of discrimination, but were embedded in good social relationships with their parents, their teachers, and their friends. There was no relationship between exposure to discrimination and biological dysregulation. In other words, the quality of social ties protected them. The National Study of Black Americans, higher levels of discrimination leads to worse mental health. 3 aspects of religious engagement: frequency of church attendance, receiving support from others at your place of worship, and seeking religious guidance in your everyday life. Each of these reduce the negative effects of exposure to the stress of discrimination on mental health. What else do we need to do? We need to create communities of opportunity, enrich the quality of neighborhood environments, increase economic development in poor areas, improve housing quality and the safety of neighborhood environments. There are lots of strategies that in this paper I showed you with Lisa Cooper that we summarize that shows these strategies work. I want to give you one example of improved neighborhood and housing conditions. They took poor residents of public housing. All they did was change the neighborhood. It led to improved health for the parents as well as for their children. There's a dramatic example known as purpose-built communities that started in an East Lake, Atlanta, that took an African-American housing project where there was a high level of crime, very poor apartments, low unemployment, and what they transformed it into the villages of East Lake, reduction in crime, mixed income housing, every able-bodied person is employed. The local school is one of the best performing in the state of Georgia. This is their model: mixed income housing, a defined neighborhood, a community quarterback, and importantly, they're providing free technical assistance to any community in America who wants to repeat their model. And so far, there are 30 purpose-built communities across these United States. I want, as I come to an end, is to emphasize that policy matters. And this is important for us in this moment. When we change the public policies that help disadvantaged populations, there are consequences. Come with me on a walk down memory lane. In 1981, we entered the era of Reaganomics, where Ronald Reagan savaged the safety net in America. 500,000 persons lost AFDC. 1 million people were dropped from food stamps. 600,000 people lost Medicaid, and so forth. And the effects were immediate and negative. It led to worse health for children. Funding cuts closed over 250 healthcare centers in the United States. It led to worse income, worse outcomes for pregnant women, with more women not receiving prenatal care. Obstetric visits at neighborhood health centers declined. High incidence of anemia in children. It led to worse outcomes for babies in America. Increasing low birth weight, increasing infant mortality in poor areas in 20 states. Folks, we are facing the same threat now. We don't have to guess what will happen. We know what happens when the system is impacted. So what can we do? What's holding us back? I've shown you evidence. We know what works. What are the barriers we have to address? We need to raise awareness levels. Do you know research reveals that more than 50% of American adults do not know that racial inequities exist? We're never motivated to solve a problem if we don't know it exists. So we need to raise awareness levels that this is a challenge. Number 2, we need to develop the political will. And number 3, we need to build empathy. We need to tell the story in a way that people can emotionally connect with so they can do something about it. One larger context I wanted to keep in mind as I talked about racial inequities tonight: all Americans should be doing better in terms of health. The United States is 4% of the world's population, consumes 48% of the money spent on medical care in the world is spent on 4% of the world's population, and the US ranks behind 66 countries on life expectancy. Even white Americans have worse health than whites in every high-income country in the world. So all of us need to be doing better in terms of health. I want to leave you with some words. Martin Luther King said, "It may well be that we'll have to repent in this generation, not merely for the vitriolic words and the violent actions of the bad people, but for the appalling silence and indifference of the good people. We cannot be silent. We cannot be indifferent. Now is the time to go to work. We need to redouble efforts to work together to build a healthier America for all. And my final slide, the words of Robert F. Kennedy speaking in South Africa in the 1960s. He said, each time a man or woman stands up for an ideal, or acts to improve the lot of others, or strikes out against injustice, he or she sends forth a tiny ripple of hope. And those ripples can build a current which can sweep down the mightiest walls of oppression and resistance. It is my hope that everyone in the hearing of my voice will decide tonight that you will be a tiny ripple of hope. And together we can sweep down the mightiest walls of oppression and resistance. Thank you very much.
You'll stand.
Stand there with the chairs. Okay.
Yes, go right.
Oh, okay, thank you.
First of all, I would like to thank you for such a great keynote. There was so much information. I have so many questions as the audience as well. You were actually giving us small little sneak peeks of so many different lectures rolled up into your 25 minutes of discussion. Thank you so much for that. So my first question for you, I would be remiss as a community pediatrician not to talk about social determinants of health and how that is impacting our community. So first of all, I would like you to discuss why social determinants of health are so critical to the outcomes of our lives, but also in the context of what community-based organizations and hospital systems are doing, because we are trying to address the social determinants of health, but where are we falling short?
As a society, we invest, as one of the latest slides I showed, 48% of the money spent on medical care is spent in the United States. And we don't have good health to show for it with other countries. 20 middle-income countries have higher life expectancy than the United States does. So don't misunderstand me. Medical care is important. I have good physicians. I go to them. I think medical care is important. Do not misunderstand me. But our healthcare system functions as a repair shop. It does a good job of taking care of us once we get sick. It is not a driver in general of whether we get sick or not in the first place. And the opportunities to be healthy is in the places where we spend most of our time. Our homes, our neighborhoods, our community centers, our churches. And so what happens in those places are important drivers of health. We need good medical care, but our healthcare system does not give sufficient attention to prevention. It is good on treatment.
Yes.
But we can give greater attention. Some countries are doing better than we are in terms of emphasizing prevention. So we need our healthcare system and we need good medical care, but we need to pay attention to what are the underlying drivers of health. And it's the exposures we have in our homes, our neighborhoods, our community environments, our resources that are the drivers of determining whether we get sick or not in the first place.
Love that answer. Love the answer. And I would add to that, when you think about traditional medicine, people come to the hospital settings to receive care. And we need to go out to the community where the people are at to do preventative medicine.
Absolutely.
So then my second part to this question, you had mentioned from one of your slides that Black and brown people tend to have better life expectancy when they are cared by people, physicians, providers that look like them, right? And that's part of the reason why I do the type of work I do and where I choose to work is to make an impact on the community. My question to you is when you don't have those resources, where you cannot have a provider that looks like you, speaks your language, knows your culture. What are the alternatives, and how can that be impactful, and how can we measure that?
There are some books that were published years ago. One was called, I think it was the People's Medical Society that published them. Take this book to the doctor with you, and take this book to the hospital with you. That really, it was an empowerment tool that would give the average layperson, what are the questions you need to ask when you go to your doctor? When your doctor says X or Y, what are the follow-up questions you would ask? So that you need to be knowledgeable, you need to be an advocate. And for many people, that might involve taking someone else with you that can help you with the questions so that you really understand and you get to the bottom of all of the issues that you want to get. So I think it's being more engaged with the healthcare system. Let me also tell you this that's important for persons who may not be disadvantaged minority person, but you're treating them. Is it possible for you to deliver good care? And there was a study from Northern California that found large patients with HIV, large racial ethnic differences in the care that they received and with the patients following through on the doctor's recommendation. Then they reanalyzed the data. They had administered what they call a cultural competence scale. And what they found was when cultural competence was high, regardless of the race of the provider, there were no racial disparities.
Wow.
What did it mean to be high on cultural competence? Providers who were high on cultural competence said that they talk to their patients of what they think is the cause of their illness, that they include their patients in the delivery of the care, that it gave a picture of a provider working together with the patient, engaging them, asking them questions, understanding where they come from, and getting them involved with the care. And when those characteristics were present, regardless of the provider race, there were no inequities. So it makes a difference for the way in which a provider relates to and engages with the patient.
I think that's so important, is that trust factor, feeling that you're welcomed and belong,
Yes.
right?
Yes.
And then when you think of your team that is caring for you, the patient is the expert in the room. You are only coming for advice, right?
That's right.
And so I think that's amazing, that power of trust and that relationship building that you have with your patient.
Absolutely.
Yes, yes. So another thing that I was really intrigued by what you were discussing about was residential segregation. So here in Rochester, in the 1940s, 50s, we had redlining, where that prohibited certain individuals to live in certain areas. And when you think of the brown and black individuals, they were concentrated in the city and not in the suburban areas where you have better school districts, bigger houses, manicured lawns, and what have you. As we move together and forward in a community, we have dismantled the redlining. But still, those imaginary lines still exist and impact not only our financial status, our education, and our health. What do you think needs to be put in place besides erasing those lines to improve the life expectancy of people of color?
It's a great question. Importantly, there is nothing inherently negative about living next to people of your own race. So the problem of residential segregation is not residential segregation per se. It's the access, the differential access to opportunity that exists, the underinvestment in neighborhoods with large populations of color. That is the problem. It's not living next to people of your own race. So the question is, we need a Marshall Plan for disadvantaged communities that says we will invest in them and ensure that they have access to the resources that will ensure good quality education, good quality access to employment opportunities, high quality housing. It's the investment in the infrastructure that produces access to opportunity is what is needed. It's not segregation per se. It's not living next to someone of your own race. It's when are we as a society going to correct the problems that we implemented, 100 years ago?
And that's crazy to me, right? All of these things that we are still going through. So myself as a physician, once married to a physician, I have kids, right? But my life expectancy is only changed by this much with my education, my income, where I live, the opportunities I have. My colleagues are all physicians, right? But then my life expectancy still has not moved that much compared to my white counterparts that have the same background as far as education, financial resources, etc. What do you think needs to happen in order for our life expectancy to mirror our white counterparts?
It's a great question. No, it's really a great question. I mean, it goes back to, I don't want to sound like a broken record, but it goes back to, we need access to opportunity. By the way, as Black professionals, one of the things that some social scientists have written about, we pay a Black tax.
Oh, do we ever?
No, so there are added burdens we bear and that we carry. And in terms of going the extra mile to make a difference for our communities, because if we didn't do it, no one would. And I need to do it with my students and so on, for example. So there is the Black tax that we also pay. But I think it goes back to a commitment as a society to ensure that everyone in this country has full access to the American dream. It can be done, but it takes a commitment, it takes a political will to say this is a direction we want to move in, and we can make a difference.
Awesome. I could speak to you all night. I could pick your brain with lots and lots of questions, but I will end with one more question. And it's really about the power of hope. We've really discussed some really grim statistics today, right? And over the last 40 years, we really have not made that much progress. What hope is out there for us? What kinds of words of inspiration, call to action do you have for me and the audience in front of you?
Yes, I go to the words of lift every voice and sing. We have come a long way, but we have come a way that with tears have been watered. We have come, trodden the path through the blood of the slaughtered. And so for me, what gives me hope and what keeps me motivated is to remember, and I get a reminder from the Equal Justice Initiative every day, of what has happened historically in this country. And the opportunities that I have, it's not because I'm special, it's because people sacrificed their lives to open the doors that I walk through. And I owe it to them, I owe it to their legacy to continue the struggle until everyone has access to full opportunity in this great nation.
Amazing. And I don't know if that doesn't inspire us, I don't know what would. Thank you so much, Dr. Williams, for all your words of wisdom, sharing that data with us, and calling us to action.
Yes. Thank you.
Thank you, Dr. Williams and Dr. Wilson, for that thoughtful and necessary conversation. You've given us not just perspective, but a challenge. Tonight's dialogue reminds us breaking barriers requires more than insight. It requires courage, partnership, and action. And now we turn to those in our own community who live that commitment every day. Please welcome our Executive Director, Ron Thomas, and our annual meeting co-chairs, Tyrese Bryant and Taylor Jackson, to present the 2025 Community Awards.
So good evening, everybody, and thank you for being with us tonight. We've got the opportunity tonight to honor an organization and two individuals who have broken barriers in our community for quite some time. Before we honor those individuals, I just want to take a moment. Is there any Baden Street staff or former staff in the building? Can you just stand up quickly, please, and just let's give those folks a round of applause, please. And if my fellow board members, can you stand up and let's honor you as well, our board members here at Baden Street. And I will turn it over to Taylor to present our first award.
Good evening. The Trent Jackson Community Impact Award honors grassroots leaders who meet people where they are and change lives one person at a time. This year's recipient, Coach Lord Johnson, has been a pillar of Baden Street for over 50 years, mentoring generations of youth, coaching across multiple sports, and guiding young people through life with discipline, heart, and unwavering belief. He's been more than a coach. He's been a teacher, protector, and lifelong shepherd to this community. We proudly present the Trent Jackson Community Impact Award to Coach Lord Johnson.
I want to thank y'all. We accept this for my dad, and thank you for being for him. He's been a pillar in our community for 50 years and beyond, so I appreciate this. My whole family, we all do, but thank y'all.
The President's Award for Excellence recognizes outstanding leadership, partnership, and commitment to Baden Street's mission. This year's recipient, FoodLink, has been a vital partner in that fight against hunger for decades, ensuring that families across our region, including here at Baden, have access to healthy, nourishing food when it's needed most. We are proud to present this year's President's Awards for Excellence to FoodLink. Accepting this award on behalf of FoodLink is Tashonda Thomas, the Chief People Officer, and Tara Keller, Chief Finance and Operations Officer. Come right over here. Sure. I'll let the AKAs get next to each other. Yeah, I don't want to. Come over. No, Taylor, get over here. Get over here.
Dr. Williams got me wanting to go back to school and become a doctor. I'm just saying. All right. Good evening, everybody. We are truly honored and humbled to accept this recognition on behalf of FoodLink's President and CEO, Julia Tedesco, who couldn't be here tonight, but she is definitely here with us in spirit, and the entire FoodLink team. We want to thank Ron, Ty, and Taylor, and everyone at Baden Street for this honor. This award is a testament to the hard work of many people, especially the employees of FoodLink. We thank them for all that they do every single day. Our partnership with Baden Street dates back decades, 3 to 4 to be exact. It's a relationship built on trust, shared values, and a deep commitment to serving our community. That's why in 2019, FoodLink proudly honored Baden Street with our Community Partner Award. We wanted to recognize and celebrate the exceptional work that you all are doing and continue to do today. Thank you for this partnership, and just again, we humbly accept this award, and just thank you again for recognizing FoodLink.
I'm just going to go slightly. Will you hold this? It's very heavy.
will.
Thank you. My partner in crime. Going a little off script, I just want to thank and celebrate Baden Street for their championing of, reducing and improving social determinants of health for the 14605 neighborhood. I know the 4,600 individuals and members you serve are so grateful for it, and we at FoodLink are thankful to have just a small input into all that you offer. Just for those who don't know, we provide thousands of meals. I believe I saw in the impact report there's about 480 children that receive meals over the year, and so those come through FoodLink. We're also excited to embark on senior meals. I saw there's about 45, and I met a couple during the social hour, so looking forward to finding another way to weave our partnership even stronger and strengthen it. And then the pantry that Baden Street has had for decades and decades, FoodLink provides the food for that. So happy to be a part of just the food access component of all the social determinant of health access they create for the neighborhood. And we look forward to many more years of partnership and strengthening it as we go forward. So thank you. Oh, those are yours.
This is a rather pensive moment for me to talk about the two men that I'm going to make in this announcement that I've had such a deep and personal relationship with over the years. Really does give me pause. The David Gant Leadership Award honors the legacy of Assemblyman David Gant, a lifelong champion for justice, equality, and opportunity in Rochester. This year's recipient, the Honorable Richard A. Dollinger, has dedicated his career to public service as a legislator, a state senator, and a respected judge. His work has impacted families across our region, always guided by a deep commitment to fairness, community, and the people he serves. We are honored to present the David F. Gant Leadership Award to the Honorable Richard A. Dollinger. A lot of years. We put a lot of years behind it.
Congratulations. Thank you. We'll grab it. All right. Round of applause.
Thank you. I am incredibly honored to accept this reminder of my good friend David Gant. I worked with him in the state legislature. Ron and I worked with him on a number of projects. And I have a secret to tell you. He didn't have a Baden Street tattoo on his arm. He had a Baden Street tattoo on his heart and his soul. Whenever he mentioned Baden Street, his smile got broader. The light in his eyes ignited like a fire, and his whole heart and soul would pour out on this community and this community center that he was so proud to be a part of. And I have to pick up one of the metaphors that Dr. Williams used about the ripple effect, Doctor, of change and how you bring about change. My friend David Gant was not a ripple. He was a tsunami. He stirred the waters of this community for justice and fairness like no one I have ever known. And tonight, as I accept this award, I give you a challenge. That wave has not yet brought about the change needed to reach the goals of a fair and just community for everyone. The success of Baden Street will be a testament to David Gant and his vision for a better future for all of us. I challenge everyone in this room to help these individuals, Baden Street staff, get to a point where the warm embrace as people enter the doors, the smile when they walk into the facility, will give them a sense that the equality of opportunity that Dr. Williams talked about will become a reality right here in Rochester through the work of Baden Street. Thank you all.
So thank you, everybody. I just want to thank you all so much for being here. What you've heard tonight is not just a reflection of our work, it's a reflection of who we are. For 124 years, Baden Street has stood where others have walked away. In neighborhoods too often written off. For families too often told to settle for less. And yet, we're still here. Because when you build trust, when you stay in the work, when you keep showing up, you build something that no system, no circumstance, and no statistic can break. The barriers are real, but so are we. And if you're in this room tonight, you're part of it. Every young person finding hope, every elder finding care, every family finding stability, every block gaining strength. That's Baden Street. So we've done too much for too long for too many to slow down now. There's nothing stopping us unless we stop ourselves. So thank you all for believing in this work. Thank you for walking with us, because together we're just getting started. And as the song says, ain't no stopping us now. Good night, everyone.
There's been so many things that's held us down, but now it looks like things are finally coming around. I know we've got a long, long way to go, and where we'll end up, I don't know. But we won't let nothing hold us back. We're putting our show together, we're polishing up our act. And if you've ever been held down before, I know you refuse to be held down anymore. Well, don't you let nothing, nothing stand in your way. I want y'all to listen, listen to every word I say, every word I say. Ain't no stopping us now. We're on the move. Ain't no stopping us now. We got to do. Ain't no stopping us now. We're on the move. I know. Ain't no stopping us now. We got to do. We got it. I know you know someone that has a negative vibe. And if you're trying to make it, they only push you aside. They really don't have nowhere to go. ask them where they're going, they don't know. But we won't let nothing hold us back. We're gonna put our show together, gonna polish up our act. Well, and if you've ever been held down before, I know you refuse to be held down anymore. Well, don't you let nothing stand in your way. I want y'all to listen to every word I say, every word I say. No. We're moving, we're grooving. We're moving, yeah. We're grooving. Moving, go. Ain't no stopping us now. We're on the move. I know we got the groove. Ain't no stopping us now. We're on the groove. Ain't no stopping us now. Oh no, I'm on the move. I really got that groove. And I know we've got the groove. Makes you wanna really move. No need in trying, no, 'cause I ain't buying. No. Don't try to stop us, no. Got the groove. I really got that groove. No need in denying, well, I ain't lying. I know. It's been far too long, well. Ain't no stopping us. It's been far too long, y'all. Just doing me while I get in line. Yeah. We're leaving the negative people way behind. 'Cause it ain't no. Please. Don't make me stop. See, I don't know where we're going or where we're gonna end up. I'm moving on. But see, we're gonna keep trying. We're gonna keep trying over and over. Yeah. I said it ain't no stopping, no. See, it ain't no way. We're gonna put our show together, we won't kind of polish up. Keep us